the end of it too. I'm kind of joking about the meditating, but meditation is so good. Do you guys know there's several studies out about meditation? How it affects your immune system. It can make your immune system like twice as strong as it is. Very good. Pulls you out of that sympathetic nervous system and puts you more into parasympathetic. So I joke about it, but I think it's a very good thing to do. Okay. So this is where we were, and okay. So looking at this is probably pretty basic for you guys, but you know, just putting these introductory explanations in for diabetes. Okay. So diabetes, you know, insulin is either, and we're going to talk about the two different types. Insulin is either not being secreted or not being taken into the cells. Okay. It can raise blood sugar from 180 to 1200. I had a patient call me once who, you know, my husband are chiropractors. I don't know why she ever called us about this, but she called and she's like, I can't see. Like, okay, you need to hang up and call 911, you know. What, is there anything you guys can do? Like, no. Her blood sugar was 800. She was drinking a case of soda a day. How regular soda. How could you ever think of a case of soda as an appropriate amount of fluids, sugary fluids to drink? So, you know, you can see it way up there. When it gets that high, though, it's going to have, you know, serious physiological effects. So, the glucose tolerance test can tell how efficiently we're using that glucose as well, how our body's taking it in, okay? So, glucosuria is going to be what happens with sugar, okay? Our kidneys, and we're going to talk about kidneys in the future, and I'll show you the anatomical structures and where this happens. But what happens in our kidneys is that the first part of the nephron, which is the tiny microscopic filtration system of the kidney, we reabsorb all of the glucose, okay, that is filtered through the blood. This is totally off the notes. You're not? Not even on that slide. Oh, you're not on that slide. Okay. So what happens, though, is those receptors that reabsorb that glucose and keep it in our bloodstream can get overtaxed if there's too much glucose. That's what happens. And so what will happen is, because they're overworked, they can't keep reabsorbing that glucose, and they'll start dumping into the urine. And that's when we start to see glucosuria. You know, we'll start to see the higher levels of glucose in the urine. Otherwise, we shouldn't see it at all, okay? 3 signs: polyuria, polydipsia, polyphagia, excessive urination, thirst, and hunger, okay? I'm kind of buzzing through this. This is familiar, right? You guys are very familiar. That's what I figured. So the breakdown: type 1, type 2. Type 1 is going to be juvenile. There's autoimmune, genetic component, possibly, okay, the contributing factors. I also think, and I may be totally off on this, but I think I may have read it somewhere, people who severely overtax their pancreas as children can have the pancreas shut down and stop releasing insulin, okay? I think that I've read that somewhere, but there's a couple contributing factors, possibly viral as well, okay? But what happens is, for some reason, those islets of Langerhans get damaged. They cannot release insulin. Okay, if they can't release insulin, you can't ferry it into cells. And the typical presentation with them, and once again, I'm buzzing through this, this is familiar as well, right, guys? Yeah, is, you know, juvenile onset, so they'll be in their teens or younger. They become extremely thirsty, very hungry, a lot of urination, and they become very skinny, right? Because even though they have glucose, they're not using it. They're not using it to be absorbed, okay? So this is only 10% of total diabetics. That I did not know the percentage, okay? We'll need the injections, okay? And now it's called insulin, insulin dependent diabetes. I think they're calling it type 1 or type 2 now because both can need the injections, okay? Type 2, we're going to see that correlation with obesity. And that correlation with obesity affects the receptors and causes that either inability for insulin to attach to the receptors, or if it can't attach, it can't get the glucose in effectively. Okay. So can be non-insulin dependent or it can be insulin dependent, depending on how progressed it gets. Okay. Just such a strong, it really scares me, the level of obesity that's happening. And we're seeing this causing, type 2 diabetes, problems with cholesterol, more deposition in the blood vessels, which causes atherosclerosis. We'll talk about that process. High levels of inflammation. Levels of inflammation in the blood can cause all sorts of disease processes, okay? So may or may not need the injections. They can take that glucophage or the anti-diabetic, I think is what they call them, right? Anti-diabetic medications, okay? 75% are overweight though. And guess who we're starting to see this now in? Kids. It's sad. It's sad. So eventually beta cells will be destroyed and become fibrous. Okay, they become fibrous, or a protein called amylin can take over. And if we're destroying those beta cells, guess what now will happen? We stop releasing insulin, and now they need the injections as well. And even if they do lose weight, they're going to permanently need the injections because they aren't going to have enough insulin being secreted. Okay. In fact, so hyperglycemia or hypoglycemia, right, if they're not careful with their insulin injections, obviously. So it's a constant balancing, right? Higher rate of infections. And this was something I never ever thought of. And this is true with diabetics, but it is also true with meningitis or encephalitis, is we have high levels of glucose in the central nervous system, which is a great medium for bacteria and viruses, right? So meningitis likes to take hold and not leave. It's a separate subject. But high levels of glucose that's kept in the bloodstream is great medium for infections as well. So diabetics are more prone to infectious processes. They get these structures where glucose attaches to a protein and it likes to get into what's called the intima, the tunica media of blood vessels. And it will harden those blood vessels. And that's why they are more predisposed to having problems with their blood vessels. But if you're getting these glycated proteins into the blood vessels that harden the blood vessels, think about capillaries. What happens with capillaries? Capillaries are the areas where we're going to have the transmission of substances from the bloodstream to the tissues. Well, if they're hardened and they have these proteins in the way, they can't get substances out into those tissues to feed and nourish them or to oxygenate them. And what happens with our diabetic patients in the distal extremities? Neuropathies. Okay. And I was actually thinking more of it's such a basic term and I can't think of it. And it happened to my mother-in-law where they just get an abscess. Okay. She got an abscess that was on her foot. And it because you can't get the blood from the capillaries out to heal it, the infection set in, and guess what happened? It started moving proximally. They had to take part of her foot out. Okay, she was totally a non-compliant patient, which was part of the issue as well. She was a real fiddler. She'd go pig out and take more. She just wasn't a good patient. But what happens with neuropathies is all the blood vessels that supply the nerves also get those glycated proteins. Can you see how insidious this disease is? It'll affect all those blood vessels, which affect all those peripheral tissues.
Eventually, that's systemic. GI. I have a patient who has
absolutely can go GI.
paralysis.
Sure, absolutely. Because what happens is the nerves get their blood supply from capillaries, and those capillaries get hard and they don't allow substances to be excreted across or secreted across. I keep saying excreted, secreted across them. okay? And you can see how that would cause macrovascular diseases and also micro, which are going to be those tiny capillaries, angiopathy, okay? The area that's thickened, I'm sorry, I said tunica media, I thought it was the media, it's the basement membrane. It's the basal area of the epithelium. That's neither here nor there, okay? Distal sores and poor healing. Decreased consciousness too, because of lack of blood for the brain, okay? If they don't have enough glucose. So nephropathy, you get thickening of the capillaries of the glomerulus. Now, you know, we'll get more into this when we get into the microanatomy of the kidney, because I really need to show this to you. But know this, there are capillaries also in the kidneys. Those capillaries are what help create what's called filtrate, which is going to be the precursor to urine. So if you're going to have an extra deposition of this, you know, this sugary protein in that basement membrane of that capillary, that's not going to be able to filter things as well, okay? So you're going to get a nephropathy. Neuropathy, we just talked about that, right? The blood supply, okay, insufficient supply of glucose. And ketoacidosis. So ketoacidosis is going to be acidity. Do we understand the physiology of this? We know ketoacidosis is when that patient is becoming what? Acidic. And what's the signs and symptoms for somebody who's going into a diabetic ketoacidosis? We're going to see them. They're going to be what? Lethargic, confused. What's their breath going to smell like? That sweet presentation. Okay. What happens with this is they cannot, either they don't have enough glucose or they're not getting the glucose into the cells. So the body kicks into play and it starts to break down fats to use as energy. Okay, it could be breaking down glycogen as well, but the process that creates ketoacidosis is we're breaking down the fats. Fats are sent to the liver to be converted into energy. The liver can only convert so many fats into energy. Then it starts to create ketones. Right, those ketones are released into the system. They can be converted into acetone. Acetone is what we smell on their breath, okay? And it creates an acidic environment. Why is that little, oh, okay, sorry. It creates an acidic environment with them. Now, one of the things that they'll try to do is they'll start breathing heavily because CO2 is acidic. So they're trying to use any compensatory mechanism possible to decrease the acidity in their body. They start to create that deep breathing because they're trying to get rid of CO2. Do you need me to write any of this down? Okay, good. They're trying to get rid of the CO2, which is acidic, to balance out their pH. That's what happens, okay? And they get that, well, that Kussmaul breathing, we know that, okay? So, not enough glucose is getting into cells either because we don't have enough glucose or we don't have insulin to do it. We break down we break down fats. Fats go to the liver. Liver can only convert so much liver into energy before it starts making acids called ketones. The ketones are acidic. They'll release and turn into acetone, creating that fruity breath. They'll also create acidity in the body systemically. The response to that is Kussmaul breathing, trying to get rid of CO2, which is acidic. It's a compensatory mechanism, okay? And you'll get that fruity breath with their breathing, okay? Can lead to acidotic coma, okay? Good. Any questions? Everybody's pretty good on diabetes, so I kind of went through that. If you have any questions at all, either come see me or shoot me an email. I'd be happy to do it. So adrenal glands are going to deal with many different forms of stress, okay? Many different forms. Well, they're all the same form, aren't they? They're going to deal with stress, okay? Your body's going to recognize it as stress. Suprarenal glands or adrenal glands, we use them interchangeably, are going to sit like that little Napoleon hat right on top of each kidney, okay? There's the adrenal medulla, which is the inner portion. Let me see if I have a picture of it. Oh, good, I don't have to draw it. Okay, adrenal medulla, and there's the adrenal cortex. So the cortex is the outer portion. There's 3 layers to it we're going to look at. This is going to release hormones that will either release glucose to be used as energy or help regulate sodium and potassium It also has some sexual hormone function, which we'll talk about. Weirdly enough, and I honestly don't even understand the correlation and why it would be there, but it's there, okay? The adrenal medulla is going to be the inner portion that's going to release epinephrine and norepinephrine, okay? Inner portion is going to release epinephrine and norepinephrine. This inner portion, the adrenal medulla, is actually pulled, it's part of the nervous system during development. And it sort of gets pulled in to the center of the adrenal cortex developmentally as we're growing. So it has a direct connection into our sympathetic nervous system, that fight or flight. So if we have some sort of traumatic event, you know, one of those 3 E's that we talked about, excitement, embarrassment, what was the third one? Excitement, embarrassment, exercise, thank you. I'm starting to get a little tired. Okay, so one of those 3 E's will trigger the adrenal medulla. It'll release norepinephrine. It's also known as adrenaline, noradrenaline. Is that what you were going to ask?
No, I've got a quick question.
Sure, yep.
What happens when you have a horseshoe kidney?
Horseshoe kidney,
Does not affect
no consequences whatsoever. Horseshoe kidney is a horseshoe kidney, okay? And it's actually, yeah, both of the kidneys, instead of being divided when we developmentally are growing, embryologically speaking, and fetally speaking, I should say, at that point, it's going to be fetus. Horseshoe kidney is just one big kidney that looks like a horseshoe. There'll be adrenal glands, because the adrenal glands are just totally separate and distinct grouping of endocrine tissue, in neurological, I should say. So, yeah, great question. Okay. So, here we go. Here's a little picture. So you can see it's sitting right on top of the kidney. There's that center portion, which is the adrenal medulla, and the cortex, which is the outside. Now, the cortex is broken down into 3 parts. So if we take a little section, you see there's a little box there, we pull that out and we move it aside. There's zona glomerulosa, fasciculata, and reticularis are the 3 layers. Okay, zona is going to be a general term for those layers, and then there's 3 different divisions, okay? And then the adrenal medulla is just simply the adrenal medulla. It doesn't have subdivisions, okay? So glomerulosa, fasciculata, reticularis, which are the adrenal cortex, and then the adrenal medulla in the center. Now the capsule is a layer of, I think it's dense irregular connective tissue. The capsule is a very firm encapsulation around both of the kidneys. If we were to cut out our kidney now, or go cut open a cat and pull the kidney out, it's pretty thick. And if you kind of separate it, it's almost like the skin of a pea, maybe twice as thick as that. And it just encapsulates the kidney, and it helps to create a protective covering around it, okay? Because it's kind of mushy once you take that capsule off. So you can see the capsule is represented at the top there, and that's going to encapsulate or cover the whole thing. Okay. So the 3 different layers are going to release our corticosteroids. Okay. So all of these are considered corticosteroids because they are made from cholesterol, which is a steroid-based hormone. Okay, that's why these are called corticosteroids. Okay. So, glomerulosa, for the most part, is going to release mineralocorticoids. Okay. The primary one that's going to be released is going to be aldosterone. It helps to balance sodium-potassium levels. It's going to retain sodium. It's going to dump potassium. If we retain sodium, what else are we going to retain? Water. If we retain water, what are we doing to our blood pressure? Increasing our blood pressure. Okay, the correlating thing that I think about with this is what happens with females before delivery. What do? They retain a fair amount of water, right? What's the body doing? It's preparing for massive blood loss, right? One of the responses to something we know is going to be stressful is to increase blood pressure by retaining sodium with those mineralocorticoids, aldosterone. We're going to retain fluids and increase blood pressure. Are you with me? Okay. Zona fasciculata, this is even more self-explanatory. This is going to be a glucocorticoid. Okay. Glucocorticoids are going to help to facilitate the release of glucose. Of course, we're going to want to facilitate the release of glucose in a stressful event because we're going to need what? Energy. We're going to need this glucose to help facilitate the energy processes that we're going to be performing. Okay. It's going to be, okay, there it is, cortisol. I didn't think I had it on there. So the primary glucocorticoid that we're going to be looking at is going to be cortisol. Okay. Zona reticularis is kind of off on its own for some weird reason. It releases what are called androgens, and androgens, excuse me, are precursors to sex hormones, testosterone, estrogen, and progesterone. Now, these are not the primary areas that we're going to release estrogen, progesterone, and testosterone. We're going to release those from our gonads, either from the ovaries or the testes in a male, okay? This tends to kick in during the initiation of hormonal release in puberty. And also there tends to be a little bit of a correlation as a male is moving into menopause. So this isn't going to be the primary release of those sex hormones. This is going to be a little supplemental release, okay? Unless there's a problem. Unless there's a problem. We'll look at those in a little bit. So adrenal cortex, hyper or hypofunction. So I think that I put, yeah, so these three, I apologize, these three are hyper, okay, Cushing's, hyper, obviously hyperaldosteronism, and adrenal virilism, and then we have hypo. So I didn't separate those out if you want to list those three as being hyper. So Cushing syndrome, glucocorticoid hypersecretion can also affect those mineralocorticoids. So there's going to be an increased level of glucose in their system because they're going to facilitate the release of that glucose. There can be an increase in sodium as well. So what will happen with them is they will be overweight. They'll be obese. They'll have something called a buffalo hump. Have you ever heard of this, a buffalo hump? There's going to be excess deposition of fat. I don't know why. Okay, I've never seen a really good explanation as to why it deposits here over C7T1. So lower cervical, upper thoracic spine. And it looks like a little, if you've ever seen a buffalo, they have kind of like a hump-like presentation. It's called a buffalo. Don't ever tell it to your patient if you know somebody who has Cushing's, because I think it sounds a little derogatory, but people will, you know, possibly say that clinically. They have a moon facies. They have a very round moon facies, okay? Weakness, hypertension would all make sense. Hypercholesterolemia would make sense as well because they're going to have extra levels of glucose and fats. Can be caused by medications or tumors is going to be a big one. Metastatic tumors, that I never knew about. Bronchiogenic tends to travel to the adrenal cortex, okay? I'm sorry, tends to release adrenocorticotropic hormone, okay? And that's going to facilitate the response and cause a Cushing's-like presentation, okay? And obviously we could do pituitary hypothalamic as well, tumors. Hyperaldosteronism is going to increase secretion of aldosterone in the cortex. Idiopathic hyperplasia, the gland also, you know, obviously tumors can increase blood pressure. This will be pretty close with Cushing's, right? Couldn't this be pretty close with Cushing's as well? Okay. Adrenal virilism is going to be exactly what it sounds like. It's going to be oversecretion of that androgens, which will cause mostly male-like presentations in females. Those androgens like to turn into testosterone. Okay, they can turn into estrogen and progesterone, but if there's an oversecretion, you're probably going to have more of an oversecretion of the testosterone. In a female, it'll cause deepening of the voice, presentation of more facial hair. Okay. This in children, when pronounced, can make a little girl's genitals look like a penis. There are pictures of it. I just couldn't put it in here. I'm sorry. But it can happen in young females. It's pretty, yeah. So hyperplasia or neoplasia or congenital causes can cause this. Okay. They would also have early development, I think I should say as well. You know, hair between the legs and in the armpits very early is a bad sign. There could be some sort of endocrinological problem there, okay? So hypocortical hyposecretion, Addison's, who knows the famous person that had Addison's disease? Does anybody know? Let's go through the signs. What? Oh, you did? Oh, and then did it remit by itself? Somebody actually had it, or did you have to take medications? Or was there a tumor?
I mean, I knew somebody that had, like.
Oh, you knew somebody who had it. I gotcha. It's a famous person. Once again, I'm probably dating myself. JFK had this. Yeah, JFK had Addison's disease. It's destruction of the adrenal cortex. There'll be suppression of ACTH. Okay. You get weakness, fatigue, appetite, and weight loss. Okay. And the weird thing, it causes a hyperpigmentation of the skin that actually makes them look healthy. They look like they have like a suntan, and for some reason, this disease will stimulate. Well, interestingly enough, well, see, okay, so melanin is what creates, I'm thinking as I'm talking here, melanin is what creates the coloration of our skin. There are little cells that release melanin in our skin, and it causes freckles or tone. It causes an increase in coloration of the skin when you're out in the sun as a protective mechanism, okay? The release of melanin can actually be stimulated by the brain as well. So I'm wondering if that's part of the correlation. But for some reason, Addison's will stimulate more release of melanin. I don't know if it's stimulating the cells in the skin or in the brain. I just thought of that as I was talking. Okay, but it'll cause a hyperpigmentation in their skin. Addisonian crisis occurs when they reach a crisis point. They can't respond to stress, right? If they can't release these hormones, they can't respond to stress. They won't release glucose. They won't retain fluid, and they can actually go into a crisis. Nausea, vomiting, hyponatremia, obviously, because they're not retaining it. Hyperkalemia, because once again, they'll retain sodium and dump potassium, okay? Hypotension, dehydration, circulatory shock can occur because they're dumping fluids, right? They're getting rid of sodium in the kidneys. Yes, do we understand that? Okay, so they're dumping fluid. Okay, so they don't respond well to stress. So what dysfunction is this going to be? Interestingly enough, out of what we just talked about, yeah, this is going to be Addison's on the right, although it's a little bit of an obscure picture because she can just be a darker coloration, right? Okay, but this is actually somebody who has a similar skin color without the disease to the lady on the left. The skin can look, doesn't she look tan? Isn't that interesting? And those melanocytes are going to be overstimulated. Okay. What adrenal dysfunction is this? This is from my anatomy book. That's why I put that mark in there. This is going to be Cushing's. You could start to see, look at her jawbone on the right compared to the left. Okay, she's starting to get that moon facies, that round facies, and you can see that buffalo hump. See, it's right over C7T1. Okay, a little fat pad there. What adrenal dysfunction? There's actually two answers to this. Can you see? You guys at home probably could see this. Maybe people here, you might not be able to see. This is a woman, okay? She needs to shave. She absolutely is having facial hair at this point. So what disease process when we deal with the adrenals could this be? Adrenal virilism, right? This could also be what? Probably. She's starting to get what? That moon facies, right, that we're going to see with Cushing. She's probably, and these are going to be interconnected, right? If she's going to have a tumor or a problem with those adrenocortical hormones, they can overlap by all means. And that's part of the reason I put this in here. Adrenal medulla is going to release epinephrine and norepinephrine, which is going to be So norepinephrine and epinephrine, guys, is also known as adrenaline and noradrenaline. That may sound a little more familiar to you. These are going to be released in stressful situations, which is known as sympathetic facilitation. The majority of it is going to be epinephrine, which is going to stimulate those sympathetic responses. Norepinephrine or noradrenaline is going to be used more as a neurotransmitter. Okay. Tumors can cause this, okay? Pheochromocytoma, okay? When we look at the adrenal medulla, I'm going to take you back for just a second. I didn't think that I put this in here, but those cells, see those round groupings of cells in the adrenal medulla? Those are known as chromaffin cells, CHROMAFFIN, chromaffin, CHROMAFFIN. So now going back, what can happen in the adrenal medulla is those cells can get a tumor. So they are called pheochromocytoma. That's the chromo refers to those chromaffin cells, okay? So obviously, what can happen is would be an oversecretion or an undersecretion of epinephrine and norepinephrine, okay? They can also get neuroblastoma. Now, this is a more generalized term for cells that, or tumors, excuse me, that can happen in the peripheral nervous system, a neuroblastoma. Okay, so that's more of just a generalized that can happen in multiple places, but because it's part of the peripheral nervous system, they can get neuroblastomas as well. I believe that these are pretty rare. Okay, hopefully. I like to think of many of these cancers as being rare. Okay, so pheochromocytoma and neuroblastoma. So gonads, male and female sex hormones, we're not going to get much into this, and we know this already, okay? Estrogen is going to cause maturation of reproductive organs. Progesterone, pro means what? For gestation, pregnancy. Progesterone is going to be one of the major hormones that we'll see with pregnancy, okay? Estrogen is going to be the regulator of maturation of reproductive organs. Testosterone is going to be from the testes. They'll produce sperm and male sex hormone, and male sex development, I should say, because testosterone is the male sex hormone. Okay. Last two for now. Pineal gland is that third eye. Oh, wow, we actually made it all the way through. Okay. Pineal gland is that third eye that's in the back of the brain. It's singular gland, okay, not known as a third eye. It releases melatonin. A couple quick things about melatonin. I like telling my nurses. Melatonin is going to regulate your sleep-wake cycles. It is a normal hormone that is released from our pineal gland that peaks during the evening. It peaks during the evening, and it starts to slow down as we get towards the morning, okay? And norepinephrine is released, and epinephrine are released as we start to wake, right? That's what wakes us up. That's why some people tend to have heart attacks first thing in the morning, because there's a little burst of epinephrine and norepinephrine. If they're close to having a heart attack, it's enough of a stimulant for their blood pressure and their heart to affect them, and they have the heart attack in the morning, okay? So epinephrine and norepinephrine are released first in the morning. The other correlating factor that they're finding with melatonin, guys, is that melatonin is an anti-carcinogen. And if you work at night, you're not going to have the regular release of melatonin in the evening. So you should probably supplement if you're not going to have a child. I should put that in there anytime in the near future, because it can actually affect your reproductive abilities, melatonin. You should supplement with melatonin when you get up in the morning, when you go to sleep during the day, because it works as an anti-carcinogen. So just a little side note for people who work at night. It also helps you get to sleep. Melatonin does. So thymus is deep to the sternum. We talked about this. That aids in the immune response. We already talked about this, the creation of those T cells. Whew, that was a whole chunk of change. Okay. Any questions? Okay. Anybody have questions at home? I'm going to stop the tape, but I'll keep streaming for a couple minutes. And next week is going to be cardiovascular. Okay. Thank you so much. Have a great week. And I'll check my messages. Thank you.